Welcome to This Just In, the show bringing you the latest advancements in healthcare, strategy, innovation, and public policy. And now, for the fastest voice in healthcare, here's your host, Justin Barnes.
Thank you for tuning in and welcome to This Just In. I'm your host, Justin Barnes. In these segments, I'll bring you the latest advancements in healthcare, strategy, innovation, and leadership. As always, we're broadcasting from the This Just In studios on the Business Radio X network, as well as Healthcare Now radio network. For this episode, my 270th episode, with a very special returning guest, Dr. Don Rucker. Most of my audience knows Dr. Rucker, as he's an industry veteran and also former national coordinator for Health IT. So again, welcome to the show, my friend. How are you?
Thanks, Justin. I'm great.
It's great to have you here again.
Before
we dive into
on the 270,
exactly,
that's very impressive.
You got it. And before we dive into to all the good stuff that we'll talk around on interoperability in the industry and TEFCA and all that good stuff, where are you calling in from?
I'm calling in from Crystal City, Virginia, which is right outside of DC. It's sort of a strip of office buildings and some residential, have a view of Capitol Hill and Washington Monument, so pretty close to DC.
Beautiful. How long have you been in that area?
Since I joined ONC.
Okay.
Yeah.
Excellent. And where'd you grow up?
I grew up in New Jersey, though, ironically enough, for the Crystal City. First job out of college was an summer internship at the EPA in Crystal City, about 4 blocks from when I live now. So in some bizarre way, it seems like my career has only moved 4 blocks.
I love it. I actually grew up in Massachusetts, but we had a place down in Cape May, New Jersey. So I spent a lot of summers down in Jersey.
Sure.
So I guess since you've been the national coordinator, what have you been up to? What are some of your passions over the last couple of years?
Yeah. Well, it's interesting. Obviously, I think as folks may know from that time, my entire career has really been about how do we get data and use data to be better in healthcare. I mean, that is literally the one thing, along with enough clinical practice to, really inform all of that in a thorough way, has been what, has floated my boat. So no surprise, as always, I'm doing more of the same. And I'm very excited to join a company called One Up Health that's doing fire in the cloud and really looking at interoperability, not just as the classic, move data from point A to point B, but how do we use data in the modern, sort of cloud, paradigm? That's a stupid word, but, in the way enabled by the cloud to really rethink healthcare, and that includes things like prevention, which we have, very little of in American healthcare. So I'm the chief strategy officer there. And, we're deep in the world of, getting data, thinking about data, cleaning up data, and leveraging the power of fire, which ultimately I think will be seen as the combo of the first time you can ever truly compute on the clinical part of care, right? As opposed to the surround, like the HL7V2 labs or DICOM, as well as the financial part of healthcare, which, historically has been X12. So fire is a way to really link those things. And as I think we'll talk about, that's increasingly huge in the policy space.
Sure. And obviously that leads me perfectly into my next question and, how we got connected here. Again, after a couple of years, what I would love to know your latest thoughts on TEFCA and some of the frameworks and where it's going.
Yeah. I think obviously TEFCA is something that was put into the Cures Act, but without a definition, really. So then, then the sort of the question is, what is the definition? Now, I think the real the real answer here is obviously, what does a modern internet do, right? I mean, we have an extraordinary networking infrastructure in America, right? This entire podcast coming and going, every aspect of it is made available by the modern internet. So field level data to manage all of these conversations, simple APIs, rich applications, right? So how do we get that into healthcare? The Cures Act, as folks may remember, had two core provisions. One is APIs without special effort, so not encumbered by having to, pay money to a vendor. The patient had computable access to their data, not through a portal. And then the other one was the right of the patients to get their data. So that's information blocking. So before, arguably, whether providers shared data with patients was somewhat optional, depending on how you look at it. But with the Cures Act, it became required, right? And in a modern way. So that's really, I think, still going to be the center point of the American healthcare system. I think we've frankly taken a side, TEFCA is sort of a sidebar to that, and has, I think, a number of features that are quite problematic from a informatics, from a computing point of view, from an economic policy, competition, consumer choice point of view. I mean, we can get into the details there, but I see the main thread being the RESTful APIs and FHIR data structures. That's the healthcare version of all the RESTful JSON stuff that you have on your smartphone that powers, a billion conversations a second, probably in the United States.
Yeah, and I think for my audience, I mean, most of us know what TEFCA is, but it's the Trusted Exchange Framework and Common Agreement. We refer to it as the acronym TEFCA, and it's obviously alphabet soup in the industry. But I guess, so going down this path, what do you see? So a couple of different levels is, first of all, the real timeline now that there are the QHIN applications in process. So what do you see there as some of the timelines? And we can kind of go into some of the other components and stumbling blocks and FHIR and all that good stuff.
Yeah, I mean, maybe just to step back, what does modern computing look like elsewhere, right? It's these RESTful APIs. Those are the gets and puts you see on your browser, right? So the whole point of that advance is, if you have an IP address, right, something.com, you can then, with OAuth 2, if the patient's authorized it, they can then get the data using the security that has been provided by the provider in, logging on to the provider systems. That's a really clean, elegant interface. There's no issue really with getting IP addresses. You type it, into your browser, or the app just gets it. What TEFCA has come up with is this network of brokers who talk to each other, who obviously have to charge potentially very large fees. So it's this brokered network, which in and of itself is frankly problematic. The second thing is they're going back to a 1990s protocol called IHE. So for the older folks on the listening in the 1990s, the internet was what were called page views. So documents. You typed in a URL, and you would get a page. It didn't really refresh. Maybe there was a query, but it really didn't do anything, right? That started changing with companies like Amazon that, allowed you to use a credit card, and then all of the programming paradigms that layered onto JavaScript. Folks may know things like React and Angular, but there's lots of them. So now everything is individual field data. So all of the things we do, change your bank account, log on to an airline, change your seat, all of that stuff requires field level data. IHE is still anchored in this document, right? So just think of it as a digital fact, the digital version of a fax. It's just there's very little there unless what you want is a human to read. Now, some people have said, controversially, oh, it's easy to compute on this. But in point of fact, computing on documents is highly problematic. CCDs are quite variable, and you have to parse it. So instead of having a simple address and a simple query, you have to write a complex program and run it for every single thing that you hope to parse out, and do so at great reliability or low reliability. So it's just, an ancient, expensive approach that's very brittle. And then, things like the almost inevitable issues with privacy and security that follow from that, come into play as well as the anti-competitive things, which unfortunately have been exacerbated by a proposed rule at my former agency.
Mm-hmm. So I guess, those are certainly some stumbling blocks. What else do you see as kind of barriers? And then obviously, where do you see as FHIR being incorporated here?
Yeah. So I think if IHE and TEFCA left to its own devices, without a government forcing function, I think it would sort of die, a eventual gradual death, just like all things that aren't enabled by computing have done in the modern internet. Now, healthcare is always a laggard, right? We still have digital faxes. But, the operational reality is what programmer is going to want to learn IHE protocols and negotiating with QHINs. It's just so much more commotion and work for such a hugely less useful result. It will die its own death. The concern, and then now I would say, since folks, like maybe including me, have made a lot of commotion about the fact that why are we going back to a 20-year-old document protocol, or older actually, in 2023, and giving that government advantage? So now Sequoia is saying, well, we're going to eventually convert it to FHIR. That sort of misses the computational point, at least half of it, because part of what makes modern computing great is that you have elegant APIs, right? You could have the elegance of FHIR, but if you hide it behind a cumbersome barrier that you can't get to, it doesn't really add value. Those are the technical things, and then we can get into the policy things that are sort of in the soup right as we speak.
Sure. Well, let's dive in there. So, I guess, from a policy perspective, and I'm obviously encouraging this, very excited to have you on air, because I still, and we talked a bit off air, I still see a lot of data blocking and information blocking out there. And it's, there's been so much work over so many, years and years, and you can even say decades now at this point. So, it's a little frustrating at times. I guess share your thoughts there, and what do you see as maybe what do we have to do, or why should I be optimistic about the future here?
Yeah. You're Justin, you're spot on, right? Why is that? It's not because we can't compute it. We've been able to compute this for decades, if you put your mind to it.
Absolutely.
We have a payment model where the margin is entirely generated, when you look nationally, by high-priced procedures.
Yes.
Right? Surgeries, certain kinds of hospitalizations, cardiac casts, all that type of stuff. And when you look at that world, that's where we have the incentives. That's where CMS and payers are paying. And so people respond to incentives, and the incentive has been to merge with every hospital site, build up an oligopoly delivery system that is so large that they become a price setter to payers. That is the business model of American healthcare. And you can see it in pretty much
everywhere.
Every market. I don't know about Sarasota where you are, but
it's on its way.
You can go, out to Miami and see it in play. You can go up to Orlando and see it in play.
Yep.
You can go to Atlanta and see it in play. You can go to North Carolina and see it in play.
Absolutely.
You know, Chicago, California, right? Every one of those markets has these oligopoly delivery systems. And obviously, without mentioning names, they're all serviced by a vendor who, again, no fault of the vendor, responding to the federal payment incentives, has built a very inward-facing platform where the ultimate economic behavior is to capture referrals within the system. I mean, if you're in these EHRs, you essentially can't refer out as a practical matter.
Right.
And then obviously the economic incentives follow. So in that world, interoperability is just an evil, right? I mean, they're trying to make themselves not interoperable, right? That's the whole point of the network design. And so, surprise, surprise, information blocking is part of that. I think what's been really disappointing to me is that ONC is now proposing to let TEFCA participants have carte blanche to information block. So what does that mean? It means that if you're an app, you're a provider, you're anybody who has ever used or had to use a QHIN for any reason and pay the tolls, the EHR vendors can now require you to get the data in the format that TEFCA supports for the data. So you don't get it in a computable FHIR bundle with a normal API that didn't even require QHINs or toll taking, that would go straight to the EHR. You're required to go, through this toll taking network and get the data in what is ultimately not a real-time computable way. I mean, that is information blocking. Information blocking is limiting access, exchange, and use. Access through QHINs, exchange through a 1990s protocol, and use by not giving you usable data. That's the problem. That ONC and the proposed rule has that as allowable is, I think, somewhere between stunning and sad. And as I've said publicly, will probably really, as is likely intended by some of the people here, shut down, a modern digital economy and keep all business in sort of our current, visit the doctor's office kind of world.
So in that direction, I mean, I guess what can we do, or what should we do? Should we continue our outreach? Is an open public comment period right now that we can respond to?
The comment period is closed. I think, we just need to, frankly, interact with ONC. Mm-hmm. If you believe in this, you can, talk with your member of Congress, have them write letters. Letters to federal agencies from members of Congress have a very interesting visibility.
Yes.
So if you're close to a member of Congress and you believe in, open APIs and modern computing and no information blocking, the proposal as currently there, it's not a final rule, it's a proposed rule, directly violates the core premises of the Title IV of the Cures Act, which is APIs without special effort and no information blocking, obviously. And then there's, I think, the question to ask, our colleagues at ONC and our colleagues at the various QHINs, why would TEFCA even need to information block? I've seen nobody who can answer why that is. Now, of course, the real reason is because it's anti-competitive, and but notionally, keeping we're here on radio, as it were, but how do you keep a straight face when you answer that question?
Very good point. No, and I think you bring up another other great point is just about, getting out there and letting your voice be heard. It's something, I've done for now 20 to 30 years on Capitol Hill and working with our members of Congress and our House and Senate and and passing legislation, getting change. And so we've done a lot of great work throughout the years and the decades. And I, highly encourage everybody to let their voice be heard. And Congress listens, I promise you. So when you go in there, you speak to your members, they listen.
Cures Act was almost unanimous. So it's a little bit stunning that an agency would effectively work to overturn that. There may also be some interesting legal aspects there on the policy and whether it was clear through the Federal Trade Commission, Department of Justice. There are a bunch of other, interesting questions that are more deeply inside the soup kitchen.
Yeah, good point. So looking back at the ONC, in your time there, what were you most proud of accomplishing while you were there?
Justin, I felt extraordinarily lucky to be handed sort of the Cures Act rulemaking as the task. When I got to ONC, I thought the issue that I had in my mind and talked about with Secretary Price when he selected me was to, clean up the remnants of meaningful use and make, charts, the things that clinicians spend a lot of time, the sort of essentially fake review of systems with 10 organ components you never looked at, and the 8 organ physical exam, right? Just stuff that was billing boilerplate and distracted from actually taking care of the patient, and getting rid of that. And, between Seema Verma and I, we actually got rid of all of that. We materially changed the nature of all clinical documentation during our term and made it far more real, which of course is critical for things like natural language processing. That's what I thought the job would be. And we accomplished that. But obviously, I've been involved in computing in healthcare since, depending on how you count, the very late 70s. And we've never really had the ability to compute on clinical care. We've been on a very slow power glide. And now finally to have EHRs everywhere, albeit with limitations, to have the modern internet. And the last building block was really the FHIR data standard, so that we had, sort of the same format to compute as opposed to proprietary data fields that, were effectively uncomputable. So putting in with, great ONC staff, the provisions on APIs without special effort, and noodling the information blocking to be fair to all, right? So to be fair to the patient who should get their data as part of the payment for healthcare, clearly, to be fair to EHR vendors who, need to have a return on their investment, and to be fair to providers who are basically, they can't really switch in EHR. So, the prices that payers can be allowed to charge them have to bear a tight relationship to the actual costs. Doing all of that was without a doubt, my lifetime accomplishment.
I love
So far.
So far, exactly. Great point. Great caveat. Completely agree. And you bring up actually Secretary Price. Ironically, Tom was my state senator and then also my congressman out of Georgia when I lived there.
Oh, wow.
Yeah.
Wow.
So the irony, the world's very small. I've actually known Tom since he was actually helped him get into the state Senate back in the early 2000s when I was doing a little bit of political work in Georgia.
Oh, wow.
Alongside my health AT stuff. So yeah.
Wow. So I indirectly owe the ONC job to you.
No. Thank
you very much. Right. Yes. Now I'll send you a card.
Thanks, Todd. Now, I've actually always admired your work. You've been a great colleague because you came from Siemens. Actually, I don't know if you know this about me, but my actually first job was in 1995 with HBO and Company, which became McKesson. So in the mid 90s, I would compete head to head against SMS. Were you there during the SMS days?
At the very end, I joined in January of 2000. But yeah, no, I'm familiar with HBOC. I actually did a business school class project on HBOC.
A good one or a bad one?
I think it was a student homework assignment.
Okay, good. So it's been a good one, maybe a positive one.
Yeah, I think expanded to a report. I'm not sure there was much information that I understood in that era or was able to communicate. So
Very cool. So we got about 30 seconds or so left to this show, but what attracted you to One Up Health, and a little bit about that?
Yeah, what's exciting about One Up Health is, historically interoperability, as we talked about at the top of the show, is, moving data from one part to another. But what I've always been interested in since literally med school is the thought of computing on data, right? Using data to figure out, for example, what are the best meds you should be on? What's the optimum prevention strategy? I mean, most today, not understood really, most cardiac disease and much cancer is actually way more preventable than people think. So how do we get computing platforms that can ingest all of that data and do it in an economically rational way? And that's where, the cloud platform comes in. So OneUp has I think, pretty unique way of using cloud. So, it's really computable interoperability as opposed to interoperability. And that's just stunningly exciting.
I love it. Congratulations, my friend. Always great to have you on air. We need to do this probably more often than every 4 or 5 years. So I'll make that happen. But again, thank you so much. It's great to have you here today, my friend.
All right, Justin. Thank you so much. Take care.
You got it. Thank you. And truly appreciate everyone taking their time to listen to us and joining us. As always, you can join us weekdays at 2:30 p.m. Eastern, 11:30 a.m. Pacific. As always, you can track me on Twitter at HIT Advisor and use the hashtag #ThisJustinRadio so I can respond to your comments from the show. If you missed any of this episode or want to hear more, all my shows are posted at Apple iTunes, SoundCloud, iHeartRadio, and TuneIn. And you check out some of the new content we just posted on justinbarnes.com. Thanks, everyone, and stay safe.